And this particular health information management program is one of the largest in the country. The numbers fluctuate quite often. So sometimes for 5 minutes, we are the largest, and then somebody will graduate like Jenna. So I will say this about Jenna, though. She is a very active member of the community, and she is definitely a representation of our global campus. So even though we're based here in Michigan, you can do a large amount of our programs completely online outside of those that have clinical features, right? So I'm gonna put an email address, not an email address, a web link if anyone is interested in any of our programs here at Davenport University, especially if you're in Michigan. We offer a plethora of discounts. So you may work for a company that we have a partnership with. So always keep us in mind. Grad certificates, masters, undergraduate, and even completion programs. So if you started somewhere and haven't finished, you can definitely stop by and we'll see what we can do for you. So I'll put that davenport.edu/apply. Without further ado, I would introduce you to Jenna Grimes. We actually met. Jenna's been here about as long as I've been in this role. We met because she brought up a course concern, and she was right. Right? She brought up a course concern, so she is a very forward-thinking individual. We're gonna greatly miss her when she is no longer part of this community as a student. But it just lets you know that we do listen to our students. So without further ado, Jenna, you have the floor, and good luck. I'm gonna go on mute, and when I cut my camera back on, that's kind of like the 2 or 3 minute warning.
Okay, perfect. Sounds good. Hi, everyone. My name is Jenna Grimes. As Dr. Brown said, I will also miss Davenport being a student here. Today, I will present my thesis on the healthcare experiences of LGBTQ+ individuals in the United States. The aim of this study is critical because LGBTQ+ individuals continue to face significant barriers and health disparities in care. These challenges weaken trust in the system and contribute to poorer health outcomes. This project explores both the issues they face and the evidence-based strategies proven to address them. Ultimately, the goal is to support healthcare providers and organizations in adopting more inclusive practices that improve patient care and overall experiences. This study examines the persistent disparities that sexual and gender minority individuals face in the United States. Many report discrimination, misgendering, or interactions with clinicians who are not well-versed in their specific health needs, leading to care environments that feel unsafe or unwelcoming. As a result, some delay seeking treatment or struggle to find providers they trust, further widening health outcome gaps, particularly for transgender and non-binary people. Understanding these experiences and identifying effective interactions is essential to advancing equity in care. For the first portion of my literature review, we're going to go over cultural competency training. Many healthcare providers start their careers without enough knowledge about LGBTQ+ health, which can lead to bias and poor communication. Studies show many feel unprepared to care for transgender patients. Targeted training, such as workshops and case-based learning, improve confidence and skills. The most effective programs emphasize cultural awareness, inclusive communication, and understanding LGBTQ+ patient challenges. Even short sessions can increase provider awareness and support more patient-centered care. This part of the literature review highlights how an inclusive curriculum prepares future healthcare providers to better care for LGBTQ+ patients. Many students receive little exposure to LGBTQ+ health topics, leaving gaps in practice. Research shows that active learning, such as real-world scenarios and interactive cases, build confidence and understanding. Structured modules improve awareness of patient challenges and support respectful communication. Reinforcing these lessons through mentorship and continued practice helps sustain these skills over time. This segment of research highlights the efficacy of simulation and applied training in enhancing student preparedness for caring for LGBTQ+ patients. Activities like standardized patient encounters, storytelling, and role-playing allow practice in realistic but low-risk settings, boosting confidence and competence. Research shows these methods improve skills, decision-making, and empathy while reducing unconscious bias. When combined with ongoing mentorship and debriefing, simulation fosters cultural humility and supports the delivery of affirming patient-centered care. In this section, we focus on the importance of inclusive data practices, particularly the collection of sexual orientation and gender identity information, for addressing health disparities among LGBTQ+ patients. Without this data, organizations struggle to develop effective interventions. Barriers exist on both sides, where patients may worry about privacy and providers may hesitate to ask. This highlights the need for clear electronic health record workflows, leadership support, and staff training to ensure respectful and consistent data collection. Collecting SOGI information is not just procedural, it reflects a commitment to acknowledging, protecting, and treating every patient with dignity. High-quality LGBTQ+ care relies on the essential synergy between ongoing professional development and comprehensive institutional support. Training is most effective when integrated with clear policies, resources, and culture of inclusivity, which also helps reduce staff burnout and boost satisfaction. Professional development equips clinicians to confidently communicate and provide affirming care, leading to measurable gains in competence. By coupling education with systemic support, organizations can achieve lasting improvements in patient outcomes and care quality. For the last portion of the literature review, both provider competence and organizational strategies shape LGBTQ+ patient experiences. Many clinicians begin practice with limited training in LGBTQ+ health, contributing to ongoing inequalities. Inclusive communication and affirming care increase patient trust, engagement in preventive services, and reduce negative experiences. Organizational initiatives like non-discrimination policies, inclusive intake forms, and trauma-informed approaches help to create safer care environments. These affirming practices also improve adherence and reduce missed appointments or delayed diagnoses. Combining provider education with systemic support leads to meaningful, lasting improvements in health and LGBTQ+ health outcomes. The study used a cross-sectional descriptive survey to capture LGBTQ+ individuals, healthcare experiences, and disparities. 50% from diverse United States backgrounds were recruited via social media, community networks, and LGBTQ+ platforms. The survey included demographics, healthcare access, gender-affirming care, healthcare experiences, policies, and open-ended feedback, using multiple choice, Likert scale, and narrative questions. Data was collected anonymously through Google Forms over 16 weeks. Descriptive statistics summarized patterns, while qualitative analysis of open-ended responses identified key themes and deeper insights. The literature review reviewed and identified 36 United States studies that met inclusion criteria from an initial 376. Effective interventions combine structural challenges, education, and policy initiatives. Key strategies include provider competency and cultural training, standardized SOGI data collection, inclusive clinical policies, expanded access to gender-affirming care, trauma-informed, and patient-centered communication. The research shows that no single intervention is enough coordinated. Multi-level approaches are needed for lasting improvements in LGBTQ+ care. The participant group consisted of 50 individuals, primarily aged between 25 to 34, with representation across several gender identities and sexual orientations. A majority identified as women, and a significant portion identified as lesbian or gay. Most respondents were white, with smaller representation from other racial and ethnic groups. About 1/5 reported having a disability. Overall, the sample offers diverse perspectives, though certain demographics are more prominent than others, which is important to keep in mind when interpreting these findings. The survey results on general healthcare access, experience, and policy for the LGBTQ+ community reveal significant systemic barriers. A substantial 64% of respondents reported that providers are only rarely or sometimes are knowledgeable about LGBTQ+ health, highlighting a critical training gap. This lack of perceived knowledge, coupled with an environment of mistrust, leads to compromised care, as a majority of 52% of patients admit to having hidden their identity from a provider. Furthermore, confidence in protective measure is low, with over half, 54% of respondents, disagreeing that healthcare policies protect LGBTQ+ patients, underscoring the urgent need for enhanced medical education, improved patient trust, and stronger non-discrimination policies. The last part of the survey results consisted of open-ended findings. and they revealed several consistent challenges that significantly affect LGBTQ plus patients' comfort and trust in healthcare. Many participants describe providers making heteronormative assumptions or expressing visible discomfort after learning about their identity. Others reported fear of being openly queer in medical settings, which shows how emotional safety plays a role in whether patients seek care. Structural issues also appeared, frequently long wait lists, difficulty finding knowledgeable providers, and barriers to gender-affirming services. Documentation problems were another big concern. One participant shared that their identity was recorded incorrectly in their chart and carried through multiple visits because staff didn't know how to fix it. Overall, these responses show that LGBTQ plus patients often face both interpersonal and systemic barriers, reinforcing the need for improved training, inclusive practices, and safer, more affirming healthcare environments. This study has several limitations. The small sample size and predominantly white participant group limit how broadly the findings can be applied. Self-reported data may also be affected by memory inaccuracies or participants' desire to present themselves in a certain way. Because the study used a cross-sectional design, it captures only one moment in time and cannot show how experiences or outcomes change over time. Additionally, collecting data through an online survey may have excluded individuals without reliable internet access, and those who chose to participate may differ from those who did not, which impacts overall representativeness. The study shows that LGBTQ plus patients continue to face gaps in provider knowledge, limited access to affirming services, and non-inclusive systems. Effective solutions combine provider education, early curriculum integration, supportive policies, and expanded access to gender-affirming care. Participants emphasize that respectful communication, knowledgeable clinicians, and visible inclusion improve comfort and trust. Meaningful progress requires ongoing training and strong institutional support to create safer, more inclusive, and affirming healthcare experiences. Thank you all for attending, and I will be open to any questions at this point.
Thank you so much for that. I had to save some questions when I spoke to you last week just for this. Talk about some struggles of the survey research. What were things that you disliked about that?
I think the biggest struggle that I faced was the length and time. It took 16 weeks, and I feel that it was really hard to get respondents on board. I went through various forms of social media platforms, LGBTQ plus community groups. I contacted so many different LGBTQ plus health centers or community centers throughout the United States, and getting responses was pretty challenging.
Yeah, so back in the day when I worked on my master's, you would have to, I stood at a nursing home because I was doing my thesis on colorectal cancer screening for Black males, right?
Yeah.
So I just had to go to a nursing home and just stand there and hand them out on paper. So the internet has made things quite easy. One thing that I would like to point out to the future students is know the difference between primary data collection and secondary data collection, right? So Jenna and I have talked, not extensively, but we've had preliminary discussions about publishing her work because of the primary, it takes more work to get primary data collection, but because of the thoroughness of it and the originality of it, now it is more attractive to publications, right? So, which gets her name out there further. About once a month, I'm published 2 or 3 times. So about once a month, I'll get a random email from somebody, hey, in this publication. So it is pretty cool from an academic sense. So we'll start off with questions from faculty and staff. I did want to say this little blurb that I didn't say at the beginning. Excuse me. That Jenna's work, this presentation is just part of a final grade. So there won't be a decision made at the end of this to say pass or fail or anything like this. We will do the total scoring prior to the grades being due next week. So if you were expecting that, I'm sorry to kill your suspense. So we'll start off with Dr. Amy, if you had any questions, and then we'll go to our advisory board members that are on. I know Carol was on, and then we'll go to our other faculty. So Dr. Amy.
Yes, hi, Jenna. Dr. Staley, Dean for the College of Health Professions. What is your background?
As far as like healthcare, well, I currently have a position as a clinical review auditor. Prior to that, I was an inpatient coder.
Very cool. Okay. With that, so I understand was the population from several sites or several areas that you did for LGBT communities, or was it one specific site that you applied the online survey?
It was several. I reached out to, I believe, over 100 people via Instagram, Facebook groups, community websites. I found a website that had listed all the 50 states of, different LGBTQ plus communities. So I would say a lot.
Yeah. Okay. So I think this is very important work. I think that I was just thinking like several, if you could even look at it in primary care physicians' offices to see like what have they implemented and has any of those items impacted how a patient, if they've been in that practice for X amount of years, that's for your dissertation, that's for your doctorate dissertation. Right?
I do that.
But I mean, trauma-informed care, that's very impactful, I feel. It's not asking what's wrong with you. It's more like what happened to you, right?
Right.
So it would just be very cool to see how you could take this and do more with it, and to have that inclusion criteria of, okay, they did this and how did it affect? So, well done. I guess I'm not supposed to say congratulations yet, but congratulations that this section is over.
Thank you so much. Thank you so much.
Can I make a comment on the question you just asked about SOGI in primary care real quick, if you don't mind?
Go ahead.
So from my experience, like during my clinical rotation, a lot of the international students found it difficult to collect SOGI information. So because I've taken a lot of ethics class, and thankfully during my basic training, one of my professors was able to actually help us hone our skills in that aspect. So during the rotation, I think we were able to help them with like the basic education on what SOGI is and and the importance like in the LGBTQ community. Also communication training, how to approach the questions humanely and remove like personal feelings from whatever it is that you think your background is. A lot of people like, find it a little bit difficult to adjust, basically.
Right.
So another thing that was helpful was hands-on training. So basically, we had to go one-on-one and then have them interview us and then give them feedback and soften their approach. I think that actually helps a lot.
Yeah,
it actually helped me, a lot.
Based on my research, I definitely agree with what you're saying. Absolutely.
Yeah, thank you for that, Sal. Who presented earlier today, and you would, because you're a physician yourself, right? So thank you for interjecting right there. It was timely. Do we have anyone else on our advisory board outside of Carol? Carol, go ahead if you had any questions or comments.
No, I think you did absolutely great, and I still do also bedside nursing contingent. So this really does hit home, especially because I work in labor and delivery. So the assumption always is, right, female, woman, but not everybody identifies that. And so obviously bringing this to surface more so in the education and how to give them the same courtesy that we give, heterosexual folks, is really big. But I think you did a great job.
Thank you so much.
And Carol, thank you for always joining these. Just another strong member of our Davenport community. So forgive me if I skip over a faculty member, but Dr. Smith, I think I said I would call you first after this morning session. So did you have any feedback?
Sure, Judge. Very, very, very good. Very needed work. One thing that you mentioned about SOGI was that clinicians aren't using it as much because of fear of offending patients. What have you seen kind of in your research that helps, I guess, from an education standpoint when when clinicians are being educated, what did you see in your research that might help them kind of overcome some of that fear to even ask the correct question or the questions that should be asked to make patients feel more comfortable?
I think that when you do like clinical intake process forms, when a patient is signing up for an appointment, if a patient's coming into the ER, a lot of it's electronic now, some of it's not. But I think that on the forms you can have pronouns, you can have sexual identity, sexual preference, preferred name, because when you don't have that, it can make clinicians feel uncomfortable to ask the question and making the LGBTQ plus individual feel misgendered or feel uncomfortable with it. So definitely having these forms that have the templates already there.
So you're saying in terms from an education standpoint, the clinicians, if they were to expand the forms, that would help alleviate some of the fear of asking the questions.
Absolutely.
Spot on. Thank you.
You're welcome. Thank you.
Very, very good.
Thank you, Dr. Smith, for taking your lunch to join us today. And then we have Dr. Copa, Jana Copa, who is an alumni of I'm speaking it into existence. Future Dr. Copa. How about that? I'm going to speak it in. Did you have any questions or comments, Dr. Copa?
No, thanks. Just great job, Jenna. Really informed. I was very well put together. Thank you.
Thank you very much.
So much. Jana, alumnus of the program and now works at Davenport University. So definitely shows you we keep ours close when they're really good contributors to the community, right? So, all right, I don't think I missed anybody. Current students, Sarah or Toya?
I just wanted to tell Jenna that I just did a great job. I did send you a message in the chat. It kind of hits home for me because my youngest brother is a part of the LGBTQ community. He's also in Tennessee, which is, South and kind of like rural and, with the disparities and then also the bias, I know that he has experienced. I was really interested in reading where they were using simulation, which I didn't know that was being used. And as working for Blue Cross Blue Shield of Michigan and trying to come up with programs to support our members that are actually of the community is really hard in the sourcing department, because when you're not educated enough, you don't know what's needed and what's out there. You do have a lot of physicians that are not educated themselves, which we see on a regular basis. So if we don't know what that community needs, then we don't know what actual services that we can provide and pay for. So I thought that was really interesting to see, something that I actually will keep in the back of my mind as we're sourcing tools to help, with our members that in that community, to help support that community. But I think you did an awesome job. Great job.
Thank you so much. And I did respond to you in the discussion board. Okay.
Toya, you got a lot to live up to this afternoon now.
I know. I'm nervous.
Sarah or Dr. Oakland?
Yeah, I was just gonna say, I was like, man, I gotta follow that up now. So great job, Jenna. I'm a little nervous now, but
don't be nervous.
It's okay, Sarah. We got this.
Great job, and I really enjoyed being in this class with you. You were always very positive in all the discussion boards, and you just really did a great job.
Thank you very much, Sarah.
Dr. Oakwood, do you
I just wanted to say congratulations on your presentation. I actually, because I think you were the first to post it, and I downloaded it to see what it. I'm like, oh my god, the graphics. I was like, oh, I cannot. What? I mean,
hard to follow.
Oh my god, I'm like, this is amazing. Well, you did an amazing job. It's a good.
Yeah,
great
you
job.
said Jenna is a future adjunct here. I'll tell all the other adjuncts, you're not gonna beat her to anything that I send out to be first. Okay, so she's first at everything. All right, family and friends that are on the line. Jenna, you would know them better than me if you have coworkers that you want to address or.
Whoever wants to ask a question or say anything, you're more than welcome to take yourself off mute, ask questions, say something. I know I have a bunch of you on here, so.
Good job, Jen. Love you.
Thank you, love you.
So proud of you. You did an amazing, amazing job. So proud of you.
Thank you, guys.
Congratulations, Jenna. I'm so proud of you.
Thank you.
Everything was really well done. It was amazing. Good job.
Thank you very much.
All right. Thank you for everything, Jenna. Thank you for your participation in the student group while you were here, and all of those things. Just like I said at the beginning, we'll compile the score of your final paper and your presentation and things like that. Paper has way more detail. Can you put your email in the chat in case anybody has any follow-up questions who may be listening to this recording after we distribute it and things like that? And then if they want to see your full paper. And then, of course, if anyone knows of any journals, I know Jenna is kind of borderline thinking about publication that would be receptive to this type of content. Please send them her way. Oh, I'm definitely not crying. Okay, someone said
That's my friend.
And our own dean has even dropped you a hint on how to expound on this for your dissertation. So I will speak Dr. Grimes into existence, right? Future Dr. Grimes.
Maybe one day.
Okay. Don't hang around us because that's just how it happens. But anyway, we're gonna stop the recording there, and then I know I will say this: if let me manage recording. Oh, there we go. Stop. I'm going to share a link with everyone. You don't have to, but I'm going to share a link with everyone. In 4 minutes, we're